Welcome to the Deep Dive. Today we are taking a fascinating and I think deeply important plunge into the internal security force of the human body, the immune system.
It really is.
We've compiled a stack of highly detailed sources that give us what is basically the ultimate shortcut to understanding immunology. We're going to cover everything from your most basic tissue defense all the way to what happens when that system turns, well, aggressive, confused, or just completely collapses.
That's absolutely right. Our sources really lay bare the architecture of how we maintain health.
Hmm.
So our mission today is to unpack that incredibly delicate balance that protects us. We're starting with the real fundamentals, the basics of self-recognition, and then moving pretty rapidly into what happens when the defense system is either too aggressive.
Which is what we see in things like allergies and autoimmunity.
Exactly. Or, on the flip side, too weak, which is the catastrophe we see in immunodeficiency, like with HIV.
So at its core, we're talking about immunity. It sounds simple, right? But it's this perpetual state of protection from illness, maintained by just a multitude of physiological defense mechanisms. It's a constant silent war being waged on our behalf.
And immunity relies on its immediate sort of generalized response system, inflammation.
Yeah.
And inflammation is a nonspecific syndrome. It's the normal, totally expected tissue response to cellular injury or an allergy or the presence of a pathogen. It's that initial protective action that, buys time for the specialist to arrive.
We should also acknowledge the silent partners in this system, which is our microbiome. These are all the microorganisms, the normal flora, that coexist in and on a person.
They're the tenants.
They really are. The tenants that live peacefully alongside our immune system, and in fact, they play a huge role in training it and keeping foreign invaders out just by, occupying the space. Understanding these three terms, immunity, inflammation, and the microbiome, it really sets the entire stage for what's to come. Okay, so let's unpack this core structure because the immune system doesn't just have one rigid strategy. It has two major and radically different pillars of defense operating at the same time, which is just crucial for comprehensive protection.
I like to think of it as having, say, a local police force and a specialized intelligence agency. The local police force is the innate immune system. This is your first line of general defense.
And it's present from birth.
It's present from the moment you are born, which makes it innate. And critically, it's nonspecific. It treats a splinter, a bacteria, and a virus all with the same immediate response mechanism. And because it doesn't learn, it is not adaptive. It reacts the same way every single time.
Okay, so that sounds highly effective for immediate threats, but what about the long game? That's where the Strategic Intelligence Agency comes in, the adaptive immune system. This is the specialized task force, the high-precision response system.
Exactly. The adaptive system is a second response, but it's highly specific. It only develops upon exposure to specific microbes or chemicals. It creates a profile for the invader. And the powerful benefit here, the feature that truly revolutionized biology, is that it results in long-term resistance. It remembers the threat.
Right.
It ensures that the second time you encounter that same bug, the reaction is faster and way more devastating to the pathogen.
That ability to remember a specific threat leads us right into a crucial distinction that I think we need to make for you, the listener, how we actually acquire immunity. It's acquired in two major ways, active and passive, and this is often misunderstood.
Let's clarify this. So active immunity means your body's doing the heavy lifting. It makes the specific defense response itself. This is durable, long-lasting immunity. You can get this naturally, like when you survive a specific infection recovering from the mumps or the flu. Your body worked hard, and it stored the memory.
Or it can be artificial, which is through a vaccination. When you get a shot, you're introduced to, a weakened or an inactive piece of the pathogen, which is enough for your immune system to build that specific, robust defense without you having to suffer the full cost of the illness. You still actively make the memory.
And you contrast that with passive immunity. Here, the antibodies are just transferred to the person. The recipient's body doesn't do the complex work of identifying the threat and building the defense. The classic, beautiful example of natural passive immunity is maternal antibodies crossing the placenta to protect a newborn baby in its first few months of life.
And the artificial version is when serum antibodies are administered, often in an emergency, like for certain snake venoms or right after an exposure to tetanus. It's fast-acting, provides immediate protection, but because the body didn't create those antibodies, they eventually degrade and the protection is gone.
It's a loan.
It's a loan, not a permanent investment. I like that.
What's fascinating here is that every single action we've just described, from that non-specific inflammation to the highly specific adaptive memory, It all hinges on one core, non-negotiable principle: the ability to differentiate self versus non-self.
This sounds like the ultimate philosophical question of the body. How do you draw the line? I mean, the immune system is constantly scanning billions of cells a day. It has to distinguish between self cells, which are the billions of cells that make up your unique body, and non-self cells, which could be foreign material, pathogens, or even damaged mutated cells that have gone rogue.
And how does it do this? How does it achieve this universal ID check?
Mm.
It's through these microscopic, highly variable identification tags, specifically the human leukocyte antigens, or HLAs.
Our sources call this the universal product code for a person, which is a great analogy, but let's deepen that.
Let's do that.
Is it just for inventory or is it actively communicating? It's actively communicating. HLAs are surface proteins found on the surface of almost every cell in your body that has a nucleus. They are highly specific to you, encoded by a very complex set of genes. The immune system, specifically the T cells, doesn't just check for the HLA, they check what the HLA is presenting.
Okay.
So if an immune cell encounters a cell without the right HLA signature, or an HLA presenting a foreign peptide, a piece of a virus or bacteria, it immediately flags it as non-self and triggers the elimination cascade. The HLAs are absolutely key for recognition and, most critically, for maintaining self-tolerance, basically teaching the developing immune system not to attack its own host.
So it's not just an ID badge. It's an ID badge that has to actively show the right credentials to be allowed through security. And this is the moment of real-world relevance for you, the listener. If you understand HLAs, you immediately get why tissue matching is so crucial for successful organ or tissue transplants. Precisely. If the HLA codes of the donor and the recipient don't match closely enough, the recipient's powerful adaptive immune system sees that transplanted organ as non-self because the surface code is different. The cytotoxic T cells, the assassins we'll meet in a bit, are immediately alerted, and that triggers an inevitable rejection unless you use powerful immunosuppressive drugs. The body's hardwired need for self-recognition makes transplantation this continuous act of biological negotiation.
Wow.
To understand the complexity of the body's defense, we really have to look at where the players come from and where they train. The immune system isn't in one specific organ like the stomach. It's a decentralized, distributed network present throughout the whole body, using the lymphatic system as its main highway.
And the factory where these defenders are made, the deep foundational production line, is the bone marrow. This is where immature, undifferentiated stem cells are produced, just waiting for their marching orders and specialization.
From these hematopoietic stem cells, we see two critical branching differentiation pathways. This is really the key to understanding the immune division of labor. The first pathway leads to the lymphoid progenitor cells.
Okay.
These cells mature into the highly specialized B cells, T cells, and natural killer cells. We need to pause here because T cells, specifically, have to travel to the thymus gland for their crucial, life-changing education. It's where they learn to tell self from non-self. The lymphoid line forms the backbone of the specific adaptive side of immunity.
So the lymphoid line is the special forces unit. The second pathway, then, must be the overwhelming general forces, the local law enforcement.
Exactly. The second pathway leads to the myeloid progenitor cells. This is a much broader group. It generates red blood cells, megakaryocytes, which make platelets for clotting, and the majority of our frontline phagocytic leukocytes, like neutrophils and macrophages. They are the immediate, non-specific ground troops.
All right, now we get to the granular detail. The job descriptions of these specialized leukocytes. It's just astonishing that every cell type has such a specific mission. Let's start with the non-specific immediate responders, the cells of inflammation.
The neutrophil is your rapid response infantry. It's typically the first wave to arrive at a bacterial infection or an injury. Its main job is non-specific ingestion and phagocytosis of microorganisms and foreign proteins. They are expendable, and they arrive in massive numbers. They live fast and die messy, contributing a lot to the pus that we see.
The macrophage and its precursor in the blood, the monocyte, is a completely different caliber of officer.
Oh yeah. The macrophage is the versatile cleanup and reconnaissance crew, the long-term occupation force. It does non-specific recognition, ingestion, and destruction of cellular debris. But crucially, it acts as a connector cell for the adaptive system.
How so?
It engulfs an invader, breaks it down, and then presents pieces of the antigen to the T cells, essentially telling the specific immune system, this is what we're fighting, now make weapons for it. So it assists with both antibody-mediated and cell-mediated immunity.
And what about the ones that trigger the visible reactions we all know? The itching, the swelling.
That's the basophil and the eosinophil. The basophil releases potent vasoactive amines, especially histamine, which kicks on that classic redness and swelling of inflammation. It also releases heparin in areas of tissue damage. The eosinophil, on the other hand, is specialized. It releases histamine and kinins, making it highly active in allergic reactions, and most specifically in fighting large parasite infestations, which are just too big for a single phagocyte to handle.
That makes the division of labor really clear for the innate system. But when we transition to the adaptive side, everything becomes highly targeted, focused on creating weapons that fit a specific keyhole. Let's look at the cells responsible for antibody-mediated immunity.
This is the B cell line, and it's responsible for the supply chain of specific weaponry, the antibodies. The B lymphocyte is the core recruit. It has to first become sensitized to a specific foreign antigen, usually with help from macrophages and helper T cells. When it successfully identifies its target, it activates and starts cloning itself.
And that clone becomes...
The resulting clone differentiates into the plasma cell. This is the antibody factory. It secretes massive amounts of highly specialized immunoglobulins antibodies, specifically designed to target that one single antigen. These antibodies then flood the bloodstream, neutralizing toxins or tagging pathogens for destruction.
And the crucial one for long-term health is the memory cell.
Exactly. This B cell remains quiet but sensitized to that specific antigen for years, sometimes decades. Upon re-exposure, it can rapidly secrete greatly increased amounts of immunoglobulins, providing that instant, overwhelming defense we associate with lifelong immunity.
So B cells are the intelligence gatherers and the manufacturing wing. Meanwhile, we have cell-mediated immunity, which is the T cell line. These cells don't launch soluble weapons. They deal in direct cellular action and battlefield command.
This group includes the commanders and the specialized assassins. The helper T cell is the undisputed command center, the central orchestrator. It enhances immune activity across all parts of general and specific immunity by secreting various chemical signals, cytokines, and lymphokines. These signals are basically chemical directives, telling D cells to start making antibodies, telling macrophages to ramp up their activity, and telling cytotoxic T cells where to strike.
So without helper T cells?
The entire adaptive system just grinds to a halt.
Wow. And the assassins.
That's the cytotoxic T cell. Its job is precision-targeted elimination. It selectively attacks and destroys non-self cells, but only those presenting the exact antigen it is sensitized to. This includes virally infected cells, cancerous cells, and as we noted, it is the primary driver of the rejection of grafts and transplanted organs.
So it's not just an assassin. It's like a specialized drone that receives a specific GPS coordinate, the antigen, and performs a targeted, often irreversible elimination.
That's a great analogy. And it's astonishing that there's a specialized cell whose entire job is peacekeeping. That must be the regulator T cell.
It is. The regulator T cell is the critical peacekeeper, the brake pedal of the immune system. It regulates the balance between offensive and defensive actions, making sure inflammation doesn't spiral into unnecessary collateral damage. Critically, it maintains self-tolerance, actively suppressing immune cells that might accidentally attack the body's own tissues.
So if this cell fails,
the rest of the immune system essentially turns into a riot, and that leads to autoimmunity.
Finally, we have the natural killer NK cell.
The NK cell is fascinating because it seems to straddle both innate and adaptive roles.
It does. It non-selectively attacks non-self cells, but it has a specific knack for detecting cells that have undergone mutation, meaning they've become malignant or cancerous. It operates outside the traditional rules of T cell activation, making it a critical early surveillance unit against internally arising threats, though it also attacks grafts and transplanted organs.
We've established the players, now let's see them in action, specifically in that immediate, non-specific response we call inflammation. This is the fire alarm going off in the body, and it's essential to understand that this is a protective mechanism, even when it's painful or inconvenient.
Yeah, inflammation is often conflated with infection, and we have to distinguish them clearly. Inflammation is the immediate protective response against tissue injury and invaders, and because it's innate, it's nonspecific, and notably, it cannot be transferred. You can't share inflammation. Infection is the invasion of pathogens like bacteria or viruses. Now, infection usually triggers inflammation, but inflammation can absolutely occur without an infection. Think about when you twist your ankle, that's trauma, or get a sunburn, which is cellular injury.
The moment of injury, the cells driving this immediate phase are the nonspecific ones we just listed. Neutrophils, macrophages, basophils, eosinophils, and those highly potent local signalers tissue mast cells, which are like stationary cousins of the basophils.
The chemical mechanisms they use are incredibly powerful and synchronized. Two really stand out as foundational. First, the complement system. This isn't a cell, it's a network composed of about 20 different types of inactive plasma proteins just circulating in the blood.
So it's like a network of inactive security cameras just waiting for a tripwire. What activates them?
They're activated by the presence of pathogens or by antigen-antibody complexes. Once activated, they cleave into these powerful fragments that act as enzymes and attracting agents. They literally complement or enhance the actions of the innate immune cells. They perform three critical tasks. They tag pathogens for easy destruction, which is called opsonization.
Okay.
They attract phagocytes to the area, chemotaxes, and some form complexes that can directly punch holes in the cell membranes of bacteria, a process called lysis. It is an incredibly sophisticated system for amplification.
The second key mechanism is the core process of getting rid of the debris and invaders, which is phagocytosis. This is the cellular vacuum cleaner operation, and our sources break it down into a clear 7-step process that is happening millions of times a day in your body.
And this process is relentless and mechanical. It just demonstrates the sheer efficiency of innate immunity.
The initial tissue damage or pathogen entry?
Chemical signals released by damaged cells like histamine and cytokines immediately draw the phagocytic cells, neutrophils, and macrophages to the injury site.
Right.
Third is adherence. The phagocytic cell sticks to the foreign material, often with help from the complement system acting like glue.
The phagocyte identifies the material as non-self. Fifth, cellular ingestion. The phagocyte extends these little arms, pseudopods, around the material, engulfing it entirely.
It is trapped.
Trapped. Sixth, phagosome formation. The foreign material is now safely contained within a vacuole inside the cell, which we call a phagosome. And finally, seventh, degradation. Lysosomes, which are organelles full of potent enzymes, merge with the phagosome, creating a phagolysosome. These enzymes then just break down and destroy the material. This cleanup is absolutely essential for healing.
The combined result of all this cellular activity, the chemical signaling, and the massive increase in local blood flow is what you physically feel. These are the 5 cardinal symptoms of inflammation, first described by Roman writers, and they are the classic outward signs of the body's defenses working hard.
They are warmth, redness, swelling, pain, and decreased function or impaired movement. These signs aren't random, they're directly connected to the structured sequence of responses. We can break the sequence down into 3 stages.
Stage 1 is vascular. This is immediate. When tissue damage occurs, the local blood vessels briefly constrict, then they rapidly dilate, vasodilation, due to the release of histamine and kinins. This results in redness and warmth at the site, primarily due to increased blood flow rushing oxygen and immune cells to the area.
Then comes stage 2, the cellular exudate stage. Because the blood vessels are dilated, their walls become leaky. Fluid, proteins, and immune cells, especially neutrophils, pour into the space. This influx of fluid causes the swelling and puts pressure on local nerve endings, causing the pain. This is where the fighting happens, and the active combat and cleanup results in the formation of pus.
And finally, Stage 3 is tissue repair and replacement. Once the threat is neutralized and the debris is cleared, the remaining white blood cells trigger the rebuilding process. This involves signaling for new blood vessel growth and, if the damage was extensive, the creation of scar tissue to permanently close the breach.
It's just so important for the listener to realize that the efficiency of this entire defense system, innate and adaptive, is incredibly susceptible to external factors. Your nutritional status directly impacts the availability of raw materials. Environmental conditions like chronic stress, certain drugs, existing diseases like diabetes, they all change your immune performance. And perhaps most notably, age. The immune system, especially in older adults, shows decreased function and delayed responses, which has to be accounted for.
Okay, so now we transition from defense working normally to defense working too hard, or more accurately, overreacting to the wrong threat. When that protective response becomes excessive, widespread, or, and this is the key difference, directed against a normal, harmless substance, that's when damage happens. We call these hypersensitivities or allergies.
Allergies are a protective mechanism that has gone rogue. They only happen in the presence of an allergen, the substance that triggers the reaction, but they are driven by immune memory. And the problems exist on a really severe spectrum, from a minor inconvenience like seasonal sniffles to rapid, life-threatening systemic reactions. To understand this, our sources delineate 4 distinct types of hypersensitivity reactions.
The one that accounts for the vast majority of common allergic complaints is type I or anaphylactic reaction, also known as rapid hypersensitivity or atopic allergy. This is the instant reaction.
This reaction is driven by the immediate, explosive release of chemical mediators. It results from the initial exposure causing an increased production of the immunoglobulin E, or IgE, antibody class. These IgE antibodies then fix themselves onto the surface of mast cells and basophils throughout your body.
So they're just waiting.
They are primed and waiting. When the allergen is re-encountered, it cross-links these IgE molecules, and that triggers the mast cells to dump massive amounts of histamine, leukotrienes, and prostaglandins in seconds.
It's that instant dumping of inflammatory chemicals that creates the rapid symptoms. And the allergens that trigger this type I reaction, they get to us in four main ways. They can be inhaled, pollen, spores, dander; ingested, foods, additives, drugs; injected, venom, drugs, contrast dyes; or they could be contacted via the skin or mucous membranes, like with latex.
And the most dramatic and dangerous manifestation of type I is anaphylaxis, which is a true medical emergency. It's systemic and life-threatening because that widespread release of mediators causes a rapid cascading physiologic collapse, massive blood vessel dilation, which causes blood pressure to plummet, a severe drop in cardiac output, and severe bronchoconstriction, which closes off the airway.
That combination requires immediate intervention. Moving past the rapid reaction, we have the other types, which are subtler but still destructive. Type 2, or cytotoxic reaction.
Type 2 is defined by the body making autoantibodies directed against its own cells that have some form of foreign protein or drug attached to them. The antibody tags the cell for destruction. You should think of incompatible blood transfusions where antibodies attack the donor's red blood cells.
Next is type 3, or immune complex reaction. This results from an excess of antigens causing small clumps of antigen and antibody called immune complexes to form and circulate in the blood.
These complexes become a problem because they're sticky. They circulate and eventually they deposit in the walls of small blood vessels in organs like the kidneys, joints, and skin, triggering localized, persistent inflammation. And this continuous cycle causes slow, cumulative damage. This is a critical point. Our sources note that most chronic autoimmune disorders, including SLE, which we'll discuss next, are actually caused by this type 3 reaction.
Finally, we have the type 4 delayed hypersensitivity reaction. This one is unique because it sort of throws out the rulebook we've been using.
It's purely cell-mediated. The key difference is that T lymphocytes, T cells, are the activated component triggering the excessive response antibodies, and complement are explicitly not involved in the primary mechanism. Sensitized T cells, having seen the antigen before, respond upon re-exposure by releasing chemical mediators and triggering macrophages to come in and destroy the antigen.
And it's delayed because
It occurs hours to days after exposure, unlike type I's minutes-long reaction. Classic examples are poison ivy dermatitis, the skin reaction to nickel, or the tuberculin skin test.
Let's ground this theory in the clinical scenario from our sources. Imagine a client who comes to the emergency department with mild shortness of breath and a runny nose. The triage notes say their lips and eyes are swollen. A potential type I reaction is suspected.
This requires immediate prioritized thinking. The sources immediately emphasize that for any swelling, particularly angioedema that affects the face or airway, the priority is securing and maintaining the airway. The focus is on the potential for rapid deterioration. And if we suspected this was caused by a new intravenous medication they were receiving, the absolute first priority would be to stop the intravenous infusion immediately to halt further exposure.
So the triage nurse is doing the investigation and discovers the client works as a nursing assistant and has known allergies to avocados and bananas. They deny eating them today. Based on the suspicion of a hypersensitivity, the doctor anticipates specific lab tests. Which ones and why?
The expected tests are immunoglobulin E, IgE, and a CBC with differential. We look for greatly increased IgE levels, as that confirms the rapid hypersensitivity mechanism. The second piece, the differential, is crucial because we are looking specifically for high numbers of eosinophils. While a normal count is about 1% in a client with a significant allergic reaction, this count might jump dramatically, sometimes as high as 12%.
And here is the fantastic diagnostic puzzle that links the environmental risk to the physiological symptoms. The client is a nursing assistant, and they have allergies to avocados and bananas. Our sources explicitly highlight that these particular fruit allergies have frequently been linked to latex contact due to cross-reactivity between the proteins. Therefore, the nurse should specifically ask about the use of latex gloves at work. This connection is a classic aha moment in occupational health related to a type hypersensitivity diagnosis.
That's
All
fascinating.
right, we've seen the immune system overreacting to external threats and allergies. Now we shift to the system getting profoundly confused and attacking the very host it is meant to protect. This is the devastating realm of general autoimmunity.
In autoimmunity, the failure is self-tolerance. Inappropriate immunity develops against an adult's own tissues because the regulator T cells, the peacekeepers, have failed or the self-identification process has been corrupted. So antibodies or lymphocytes are directed against the body's own healthy, normal cells. And this is chronic, progressive, and unfortunately self-perpetuating. The system just keeps feeding the internal attack.
The definitive multi-system example we are examining is systemic lupus erythematosus, SLE. This is not just a skin condition. It's a chronic, progressive, body-wide autoimmune disorder where tissue integrity is lost due to excessive, misdirected inflammation, which tragically often leads to organ failure and death over time.
To understand SLE, we have to revisit those type 3 reactions. The mechanism is a global catastrophe because the autoantibodies involved are largely directed against structural proteins found right inside the nucleus of the cell, specifically anti-nuclear antibodies, ANAs. These circulating antibodies then form immune complexes that attack tissues throughout the entire body.
Why does this happen? Our sources highlight a very strong genetic connection and susceptibility. But it takes more than just genes. There are numerous triggers that can initiate or exacerbate the disease. These include viral infections, certain drugs, hormonal factors, which is maybe why it affects women so much more often, and a massive environmental trigger, exposure to ultraviolet rays and sun.
The incidence is sobering. Our sources state that 1.5 million adults are living with SLE in North America, which is about 1 in every 1,000 people in Canada. And the gender disparity is overwhelming. It primarily affects women, often starting in their childbearing years.
When assessing a person with SLE, the clinical manifestations can be frighteningly systemic because the immune attack is directed against cellular nuclei throughout the body. There's no safe harbor.
Right. The key physical assessment cues span multiple systems. While the characteristic sign is that famous malar rash, the butterfly rash, across the face, other skin changes are common. Internally, the patient experiences intermittent low-grade fever and profound, unremitting chronic fatigue. Musculoskeletal changes are inevitable, often including painful arthritis and osteonecrosis, the death of bone tissue. And because of those sticky immune complexes, the kidneys and the cardiac system are often severely damaged.
It's clear that managing SLE is about managing a state of chronic war within the body. And beyond the physical symptoms, the psychosocial impact can't be overstated. Dealing with chronic, unpredictable flares, persistent pain, and devastating fatigue means patients may start avoiding social and family gatherings.
Absolutely. When providing care, it's critical to provide active listening and create a prioritized plan that acknowledges the relentless nature of the disease. The clinical analysis in our sources focuses on managing the inflammation and its outcomes, yielding 3 prioritized hypotheses for care.
Which are
1. Persistent pain due to chronic inflammation. 2. Fatigue due to chronic inflammation. And 3. The potential for organ failure due to that chronic inflammation and vasculitis.
Therefore, the planning and implementation of management has to be long-term and coordinated. The focus is on managing persistent pain, managing the debilitating fatigue, and most critically, preventing that cumulative, irreversible organ damage, all while reducing the frequency of SLE activity periods.
The ultimate evaluation of success isn't curing the disease, but stabilizing life within it and extending periods of remission. The goals for the patient have to include adhering to the long-term management plan, managing pain at an acceptable level, maintaining energy for important activities, and experiencing longer periods of remission with low SLE activity.
We've moved from overreaction, allergy, and misdirection autoimmunity to the ultimate catastrophe, immunodeficiency. We're talking about HIV, the human immunodeficiency virus, where the central command of the adaptive immune system is fundamentally dismantled.
HIV is a crucial concept because it highlights the catastrophic consequences of taking out the orchestrator. The etiology involves HIV-1 and HIV-2, and while there are environmental factors for transmission, research shows that susceptibility to infection may be partially heritable, which adds another layer of complexity.
Here's where it gets really interesting. The mechanism of attack. It's a masterclass in biological hijacking. HIV targets the helper T cell, specifically the CD4 plus T cell. If you recall, this is the command center we defined earlier, the one that signals B cells, macrophages, and cytotoxic T cells.
And when HIV successfully enters a CD4 plus T cell, that cell's fate is sealed. It immediately stops functioning as an active immune cell. Instead, its DNA is hijacked, forcing it to become a virus factory, solely dedicated to replicating HIV. As this process continues, the overall CD4 plus T cell count gradually falls, viral numbers, the viral load rise, and the entire immune system just weakens across the board. The adaptive response collapses because the general is gone.
This collapse is defined by the stages of HIV progression. Stage 1 is acute HIV infection, Stage 2 is chronic HIV infection, and Stage 3 is acquired immunodeficiency syndrome, or AIDS.
And this is the critical distinction we want you to grasp. Everyone with stage 3, AIDS, has HIV, but certainly not everyone with HIV has AIDS. The progression is tied directly to that CD4 plus count and the presence of defining illnesses.
Let's detail that classification because the numbers are the clinical yardstick for determining how vulnerable the patient has become.
Right. So, class 1. The patient has a robust CD4 plus count, greater than 500 cells per millimeter cubed. They have HIV, but the immune system is relatively intact. No AIDS-defining illnesses are present.
Okay.
Class 2. The CD4 plus count is showing significant decline, sitting between 200 and 499. Still, no AIDS-defining illnesses have been documented yet.
And in the threshold.
Class 3. AIDS. This is the critical threshold. It's defined by a CD4 plus count of less than 200, or a CD4 plus percentage of less than 14%. But crucially, if a patient has been diagnosed with any AIDS-defining illness, like pneumocystis pneumonia, they are immediately classified as Class 3, regardless of what their current CD4 plus count happens to be. That 200 threshold is critical because it represents the point where the immune system can no longer fend off common environmental pathogens.
The virus is so insidious because of how cleverly it initiates the infectious process. It knows exactly which door to knock on, and it requires not just one receptor, but two for successful entry.
That's right. The HIV virus uses the CD4 plus T lymphocyte receptors as its primary gateway, but it needs a co-receptor, either CCR5 or CXCR4, to successfully fuse and enter the cell. This docking and fusion is the first step in hijacking the cell, and it leads directly into the sophisticated life cycle of the virus. Understanding these 7 steps is vital because they show exactly where modern drug therapies are targeted.
Let's walk through the viral life cycle and the corresponding drug defenses.
Okay, step 1, binding. The virus attaches to the CD4 plus and its co-receptors. 2, fusion. The viral envelope merges with the host cell membrane. This is targeted by entry inhibitors, which prevent the virus from physically entering the cell.
Right.
3, reverse transcription. The virus contains RNA. It must use an enzyme called reverse transcriptase to convert its viral RNA into viral DNA. This is targeted by reverse transcriptase inhibitors, NRTIs and NNRTIs, which block this conversion.
A key step for a retrovirus.
Absolutely. 4, integration. The new viral DNA is transported into the cell's nucleus and inserts itself into the host cell's DNA. The cell is now permanently infected. This is where integrase inhibitors work.
Okay.
5, replication. The host cell now treats the viral DNA as its own, making viral proteins. 6, assembly. New viral components gather near the cell membrane. And 7, budding. New immature virus particles pinch off from the cell. And before these new viruses are mature and infectious, they must be processed by an enzyme called protease. This final step is blocked by protease inhibitors.
That 7-step process and the 5 corresponding drug targets demonstrate the incredible scientific complexity of modern antiretroviral therapy, or RT. When a patient takes a combination of drugs, a cocktail, they're attacking the virus at multiple points in its life cycle, which is essential to keep the viral load suppressed.
Despite massive progress, globally, the prevalence is still immense. As of 2021, there were 38.4 million people in the world living with HIV, and it disproportionately affects certain populations due to societal and economic factors.
Transmission remains a critical public health concern. The 3 main routes are sexually, parenterally, so via blood or injection drug use, and perinatally from mother to child.
And prevention strategies have evolved significantly. We've moved beyond just behavioral change to targeted prophylactic prevention. This is where pre-exposure prophylaxis, POPP, comes in. Pre-P is a drug regimen taken daily by people who are HIV negative but at high risk. Then there is post-exposure prophylaxis, PEP, which is an emergency course of medication taken after a suspected exposure.
We also utilize strategies like strict universal precautions in healthcare, and perhaps most powerfully for community health, treatment as prevention, TASP. CASP means that if a person living with HIV is adherent to their drug therapy and their viral load is suppressed, meaning it's undetectable, the risk of sexual transmission is considered scientifically negligible. This turns treatment into a public health tool.
It's revolutionary. When analyzing the care needs, the focus is twofold. First, addressing the potential to transmit infection due to a lack of health education or risky behaviors. And second, and increasingly severe as the disease progresses, addressing the severe potential for infection and life-threatening complications due to reduced immunity.
Therefore, the intervention and planning focuses intensely on generalized infection prevention, strict adherence to drug therapy, managing symptoms like compromised gas exchange, pain, enhancing nutrition, and preserving skin integrity, as opportunistic infections often show up on the skin.
The long-term evaluation goals are clear. The patient must refrain from spreading the HIV virus to others, and they must avoid developing acute and opportunistic infections. Success is measured by long-term viral suppression and the high quality of life.
As we wrap up our look at the immune system and its spectacular failures, let's briefly touch on another common immune challenge that perfectly illustrates the concept of chronic inflammation caused by an outside invader: Lyme disease.
Oh, Lyme disease, caused by the Spirochete bacterium Borrelia burgdorferi, is a perfect example of a pathogen that causes chronic, long-term inflammation if it isn't caught and treated with antibiotics early. It's transmitted by ticks. Stage I usually involves flu-like symptoms and that very recognizable erythema migrans, or bullseye rash.
But if it's untreated, the bacteria can spread and lead to severe, persistent symptoms. It can progress to stage 2 and the third, where it begins affecting the joints, the heart, and the nervous system, leading to chronic neurological inflammation. It's an example where a simple bite can set off systemic, long-term inflammatory destruction.
And prevention here is entirely environmental. It's all about tick avoidance. Staying out of heavily wooded areas, using insect repellent, wearing long-sleeve tops and pants, and immediate, proper removal of any ticks you find. It's a clear case where external behavioral defense is the best immune strategy.
Absolutely. If we connect all the dots from this deep dive, from the immediate fire alarm of inflammation to the specific memory of adaptive immunity, the entire security architecture hinges entirely on that first core principle we discussed: the ability to recognize self.
And what we've explored today shows the full, devastating spectrum of failure related to that recognition. We saw hypersensitivity as an overreaction to a harmless external factor. We saw autoimmunity as a deadly misdirection, where the system attacks the self in a type 3 immune complex reaction, like in SLE. And finally, we saw immunodeficiency as the structural collapse of self-protection against invaders, as we detailed with HIV.
All these chronic conditions are rooted in disturbances of those original foundational concepts of defense and recognition.
Exactly.
And that leads us to the final thought for you to consider, something to mull over. We noted today that several major immune challenges, like susceptibility to HIV and the onset of lupus, are partially heritable, suggesting a strong genetic influence. If we continue to gain precision in identifying specific genetic predispositions to these major diseases, what ethical and practical implications does that have for preventative medicine? How should personalized medicine tailor lifestyle interventions, like aggressively managing sun exposure for those with a high genetic risk of SLE or promoting PP for specific risk populations when we know their susceptibility is partially written into their DNA? It really forces a new conversation about individual responsibility versus biological destiny in healthcare.